Bismillahirrahmanirrahim. In the last session, we were talking about the squamous cell carcinoma, and we abruptly stopped at, I guess, leukoplakia or something. So let's restart on the squamous cell carcinoma. So, malignant squamous cell carcinoma is a malignant neoplasm of squamous cell lining of the oral mucosa. Tobacco, alcohol are the major risk factors for that. Floor of mouth is the most common location. The oral leukoplakia and erythroplakia are the precursor lesions. Leukoplakia, leuko means white and plakia is a plaque, so it's a white plaque that cannot be scraped away, often represents the squamous cell dysplasia, and the scraping away discriminates, like you cannot scrap away the leukoplakia, but there is another white plaque that can be scrapped off, and that is a candidiasis, right? So that is the differentiating point between the two. Leukoplakia is distinct from oral candidiasis and hairy leukoplakia. Oral candidiasis is a white deposit on the tongue which is easily scraped away, usually seen in the immunocompromised states. And hairy leukoplakia is a white, rough, hairy patch that arises on the lateral tongue. It is usually seen in the immunocompromised individual, for example, the people with the AIDS, and is due to Epstein-Barr virus-induced squamous cell hyperplasia. It is not pre-malignant. The oral hairy leukoplakia, although it is presenting in the people who are immunocompromised, and is caused by Epstein-Barr virus, but it is not pre-malignant. Erythroplakia represents the vascularized leukoplakia and is highly suggestive of squamous cell dysplasia, and that is a pre-malignant condition. Erythroplakia and leukoplakia are often biopsied to rule out carcinoma. So this is leukoplakia, here is erythroplakia, this is candidiasis, and this is hairy leukoplakia. Salivary gland. Firstly, we'll talk about mumps. Infection with the mumps virus result in the bilateral inflamed parotid glands. Parotid gland, like you know where the parotid glands are. Orchitis, pancreatitis, and aseptic meningitis may also be present. Serum amylase is increased due to the salivary gland or pancreatic involvement. Orchitis carries risk of sterility, especially in the teenagers. Usually does not occur before the age of 10. Suppurative parotitis in the adults. The risk factors: decreased salivary flow. So whenever there is stagnation, there is a risk of bacterial growth, and that decreased salivary flow is caused by the medications like anticholinergics, obstruction, for example, by the calculi or neoplasms, and dehydration post-surgical or post-intubation, I guess. So that can lead to, like, if the person is intubated, so the person is not taking, drinking water, and that can cause suppurative parotitis in the adults. Microbiology, Staphylococcus aureus, and anaerobes. The clinical presentation is firm erythematous pre-post auricular swelling. Trismus is locked jaw, dysphagia, systemic findings, fever, and chills. The diagnosis is imaging ultrasound CT that will show ductal inflammation and obstruction, and there will be a frank abscess as well. The lab evaluation will show elevated serum amylase without pancreatitis. The salivary gland tumors, most commonly benign and in parotid gland. Tumors in smaller glands, more likely malignant, typically present as painless mass or swelling. Facial pain or paralysis suggests malignant involvement of the CN7. So the pleomorphic adenoma and mucoepidermoid carcinoma and Warthin tumors are the main salivary gland tumors. Pleomorphic, as the name indicates, contains different type of morphologies. It is a benign mixed tumor, most common salivary gland tumor. It is composed of chondromyxoid stroma and epithelium and recurs if incompletely excised or ruptured intraoperatively, may undergo malignant transformation. The problem with the pleomorphic adenoma is that it has multiple appendages. So if due to some reason you excised this much tumor and any of the appendages left, it can regrow. So the biggest problem with the pleomorphic adenoma resection is the regrowth or recurrence. The mucoepidermoid carcinoma, most common malignant tumor, has mucinous and squamous components. The Warthin tumor, which is also called as papillary cyst adenoma lymphomatosum, it is a benign cystic tumor with germinal centers. It has germinal centers, typically found in smokers, bilateral in 10% and multifocal in 10%. So warriors from Germany love smoking. So this picture represents pleomorphic adenoma. Note, irregular surface of the tumor makes it hard to be excised completely and has a high recurrence rate. So starting with the esophagus, so esophageal webs. Now suppose this is the esophagus and if the mucosa protrudes inwards, so that will make a web-like structure. Thin protrusion of esophageal mucosa, most often in the upper esophagus. It presents with dysphagia for poorly chewed food. So if you don't chew the food properly, so there is a chance that some large food bolus may become stagnant over here. So that will become so the esophageal webs, they cause dysphagia for poorly chewed food, increased risk of esophageal squamous cell carcinoma, The Plummer-Vinson syndrome is characterized by severe iron deficiency anemia, esophageal web, and beefy red tongue due to atrophic glossitis. So I guess it is a triad. In Plummer-Vinson syndrome, we have dysphagia, oral esophageal webs, and iron deficiency anemia. And on physical examination, we will find a beefy red tongue due to atrophic glossitis. In achalasia is basically the problem the when the lower esophageal tone is too much and that does not relaxes on the entry of the food, and that happens because of some degeneration of the myenteric nerve plexus that was supposed to release nitric oxide or relaxing peptides which was supposed to relax the lower esophageal sphincter. So the lower esophageal sphincter is unable to relax and that results in dysphagia. Failure of lower esophageal sphincter to relax due to the loss of myenteric Oribeck plexus due to loss of post-ganglionic inhibitory neurons which contain nitric oxide and VIP. Both of them are inhibitory and cause relaxation of smooth muscle, and if that will not happen, so lower esophageal sphincter will not relax. Manometric findings include uncoordinated or absent peristalsis with high LES resulting resting pressure, progressive dysphagia to solids and liquid versus obstruction that is to solids only. Barium swallow shows dilated esophagus with an area of distal stenosis bird beaks. So here you can see that this point cannot relax. So this is stenosed, and proximal to that, because of accumulation of food and liquids, the area is dilated. So this is bird's beak appearance, and associated with increased risk of esophageal cancer. Achalasia is absence of relaxation. Achalasia can be secondary, like secondary achalasia or pseudoachalasia may arise from Chagas disease, Trypanosoma cruzi infection, or esophageal malignancies, mass effect, or paraneoplastic. Now, it is diffuse esophageal spasm in which we have a corkscrew appearance. Okay. I guess in achalasia, in carcinomas, the problem is that we have progressive dysphagia, but in achalasia, the dysphagia is for both solids and liquids. In diffuse esophageal spasm, the periodic non-peristaltic contraction of large amplitude and long duration that will lead to dysphagia with chest pain that mimics the unstable angina. That is one of the differentials of angina as well. Esophageal contractions are normally stimulated by the esophageal distension from a food bolus. The contractions originate above the site of distension and propel the bolus downward in a coordinated fashion. In diffuse esophageal spasm, several segments of esophagus contract inappropriately at the same time, which appears as disorganized non-peristaltic contractions on esophageal manometry and corkscrew esophagus on barium esophagogram. Because the food bolus is inefficiently propelled towards the stomach, patients typically present with intermittent solid-liquid dysphagia, chest pain, heartburn, and food regurgitation. The pathogenesis of diffuse esophageal spasm likely involves the impaired inhibitory neurotransmission within the esophageal myenteric plexus. So the pathogenesis is kind of similar to the achalasia, but the difference is that there we find a corkscrew appearance, and in achalasia there is absolute absence of relaxation of the lower esophageal sphincter, giving the bird's beak appearance. Talking about Mallory-Weiss syndrome, it is a syndrome that is most commonly present in the people who vomit a lot. So these are like the patient will be either bulimic, like, or maybe the patient is alcoholic. So because of retching and vomiting, there are vertical tears in the mucosa of the esophagus. Mucosal laceration at the gastroesophageal junction due to severe vomiting. It leads to painful hematemesis, usually found in the alcoholics and bulimics. Painless hematemesis is manifestation of portal hypertension, while painful hematemesis is manifestation of Mallory-Weiss syndrome. Then comes the Borjev syndrome. Borjev syndrome is ruptured esophagus that causes air to enter the mediastinum. It is transmural, usually distal esophagus rupture with pneumomediastinum as shown by the arrow A. So this is air in the mediastinum around the aorta. Due to violent retching, surgical emergency, there will be Hamman sign, crunching heart sound due to pneumomediastinum. So when you auscultate the heart, there will be a crunching sound, and that is Hamman sign, visually positive. Characteristic of gastroesophageal mural injury. Etiology: Mallory-Weiss syndrome and Borjev syndrome. For Mallory-Weiss syndrome, upper gastrointestinal mucosal tear caused by forceful vomiting and increased intragastric pressure, submucosal arterial or venous plexus bleeding. The clinical presentation include vomiting and retching, hematemesis, and epigastric pain. For Borjev syndrome, the etiology is esophageal transmural tear. It is caused by forceful vomiting, that is increased intragastric pressure, esophageal air or fluid leakage into the mediastinum and pleura. The clinical presentation is vomiting and retching, chest and upper abdominal pain, fever, dyspnea, and septic shock rapidly ensue after that. So Mallory-Weiss syndrome, tear on the gastric side of the gastroesophageal junction, which may extend to the distal esophagus, that will result in hematemesis. So there is a tear that can cause upper GI bleeding. Incomplete tear only affects the mucosa and submucosa. The Borjev syndrome, so in Mallory-Weiss syndrome, the tear is incomplete. In the Borjev syndrome, we have transmural tear, complete rupture of the lower thoracic esophagus that can result in subcutaneous emphysema, chest pain, and shock. A Mann sign, that is crunching sound on auscultation of the heart due to the pneumomediastinum. Then comes the eosinophilic esophagitis. It is one of the differentials of GERD. Infiltration of eosinophils in the esophagus is often atopic patients. The people who have predilection to develop IgE-mediated disorders are atopic patients. The people who are allergic, basically. Food allergens will cause dysphagia and food impaction. Esophageal rings, as you can see in this picture, there are a lot of esophageal rings, and linear furrows often seen on endoscopy, and unresponsive to GERD therapy. Like, it is a differential of GERD. We are treating the patient for GERD. If the person is not responding, then do the EGD and also do the biopsy. Now on biopsy, you will find a lot of eosinophils. Esophageal strictures are associated by caustic ingestion and acid reflux. Either the person has ingested something, or in the person with GERD, the acid from the stomach is refluxing back to the esophagus, causing the esophageal stricture. Then comes esophageal varices. Varices are basically the venous channels which are normally present in the lower esophagus, but in the people with the portal hypertension, they become dilated and tortuous, and they have a chance of rupture. So dilated submucosal veins, as you can see in this picture, picture B and also in the C. So these are submucosal veins which are dilated in the lower one third of the esophagus. Secondary to portal hypertension, these are common in cirrhotics and may be source of life-threatening hematemesis. Then esophagitis, as the name indicates, it is the inflammation of esophagus. So there will be some inflammatory etiology, like either an infection or something else. Mostly it is infectious. So let's talk about that. It is associated with a reflux. Infection in immunocompromised, like with the Candida white pseudomembrane. HSV1 causes punched out ulcers, and cytomegalovirus causes linear ulceration, caustic ingestion, or pill esophagitis. For example, bisphosphonates, tetracycline, NSAIDs, iron, and potassium chloride. You must remember the names of these drugs because they are causing pill esophagitis. After ingestion of drugs, there can be esophageal inflammation causing the pill to stand within the esophagus. So that is the bisphosphonates, tetracyclines, NSAIDs, iron, and potassium chloride. Then we have esophagitis white pseudomembrane are formed due to the Candida esophagitis. Linear ulcers are formed because of cytomegalovirus, and punched out ulcers are formed because of HSV1. Candida esophagitis endoscopy typically shows white plaques on an erythematous mucosa. Light microscopy demonstrates pseudohyphae and budding spores embedded in necrotic debris. Cytomegalovirus esophagitis usually presents with odynophagia, that is pain with swallowing, or dysphagia, that is difficulty swallowing, that can be accompanied by fever or burning chest pain. Endoscopy typically shows linear and shallow ulcerations in the lower esophagus that sometimes diffusely involve the esophagus. The tissue biopsy will show enlarged cells with basophilic or eosinophilic intranuclear inclusion bodies, that is hallmark of cytomegalovirus. Owl's eye inclusion bodies are present. So here it is picture of Candida, like you can see the white plaques. In herpes simplex virus, these, if you can see, so this is a punched out ulcer, also this one and this one. And in cytomegalovirus, you can find linear ulcerations, like it's starting from here and going all the way till here. Then comes a gastroesophageal reflux disease, GERD. It commonly presents with heartburn, regurgitation, dysphagia. Heartburn means retrosternal burning, chest pain. It may also present with chronic cough, hoarseness, that is laryngopharyngeal reflux. It is associated with asthma, transient decrease in lower esophageal sphincter tone. A Uworld point about silent GERD is that in silent GERD there is dysphagia with nocturnal cough, sore throat, and there will be no heartburn. Acidic gastric contents irritate the esophageal mucosa, leading to characteristic histologic findings that include basal zone hyperplasia, elongation of lamina propria papillae, and scattered eosinophils. So that is why eosinophilic esophagitis is one of the differentials of GERD. The Uworld point is new onset odynophagia in the setting of chronic esophageal reflux disease indicates the presence of erosive esophagitis and the formation of an ulcer in the esophagus. The diagnosis is made by upper endoscopy. Then comes the Plummer-Vinson syndrome. There is the triad of dysphagia, iron deficiency, anemia, and esophageal webs. It may be associated with the glossitis, increased risk of esophageal squamous cell carcinoma. So Plummer die. So dysphagia, iron deficiency, anemia, and esophageal webs. Sclerodermal esophageal dysmotility. Esophageal smooth muscle atrophy leads to decreased lower esophageal sphincter pressure and reduced motility. That will lead to acid reflux and dysphagia, ultimately stricture, Barrett esophagus, and aspiration. It is a part of CREST syndrome. So CREST syndrome is basically the mnemonic that we have made for the limited scleroderma, in which we have cutaneous involvement, Raynaud phenomena, esophageal dysmotility. S was for sclerodactyly, and T was for telangiectasia, then C is for something, I guess it is conjunctivitis or something, but I don't remember. We'll discuss that in the rheumatology unit, inshallah. Then Uworld point is the case is that severe heartburn resistant to the treatment with fingertip ulceration and multiple telangiectasias. So that is CREST syndrome. Esophageal dysmotility will lead to GERD that causes esophageal. The cause of esophageal dysmotility is the atrophy of the atrophy and fibrous replacement of the muscularis in the lower esophagus. Got it. So the CREST syndrome, C means calcinosis. Okay. So calcinosis, calcium deposits in the skin. C also means for anti-citrullinated peptides, which are the antibodies. No. It is anti-centromere antibodies. Yes, anti-centromere antibodies. Okay, R is for the Raynaud phenomena, spasm of the blood vessels in response to the cold or stress. E is for esophageal dysfunction and acid reflux and decrease in motility of esophagus. S means sclerodactyly, thickening and tightening of the skin of the fingers and hands. Telangiectasia is T, dilation of the capillaries causing the red marks on the surface of skin. Barrett esophagus, specialized intestinal metaplasia. So basically, when esophageal mucosa is non-keratinized squamous epithelium, when it is exposed to the acid for a very long time, which it is not used to, so that becomes that adapts to that acid exposure, and that becomes intestinal like columnar epithelium with goblet cells to resist the acid. So, specialized intestinal epithelial metaplasia, replacement of non-keratinized stratified squamous epithelium with the intestinal epithelium that is non-seriated columnar with a goblet cell that is stained blue in the picture B, if there is a picture B. Okay, so this one. So, due to the chronic gastroesophageal reflux disease and associated with increased risk of esophageal adenocarcinoma. So, here you can see that normally this is squamous lined esophagus and this is columnar lined esophagus because of the GERD, gastroesophageal junction. So this is intestinal metaplasia happening over here. This is squamous mucosa and these are the goblet cells. This is cardiac mucosa. Cardiac means the mucosa of the cardia of stomach, and this is squamous mucosa. So okay, so in this picture you can see that the goblet cells are being formed and the intestinal mucosa the esophageal mucosa has become columnar like the intestines mucosa. Esophageal cancer. It typically presents with progressive dysphagia first for solids and then for liquids and weight loss, and it has a poor prognosis. It is of two types, squamous and adenocarcinoma. Squamous cell carcinoma preferentially affects the upper two-thirds of the esophagus. The risk factors include alcohol, stored liquids, caustic strictures, smoking, and achalasia. The prevalence is it is more common worldwide. Adenocarcinoma affects the lower one-third, and the risk factors like chronic GERD, Barrett esophagus, obesity, smoking, and achalasia. Because if you remember, we just have talked about the goblet cell formation and intestinal metaplasia in the cases of GERD and Barrett esophagus. So these goblet cells, which are glands basically, so they cause the formation of adenocarcinoma. So that is most common in America. The Uworld point is the most important risk factor for squamous cell carcinoma is smoking and alcohol. Major risk factor for esophageal cancer, squamous cell carcinoma, the most common is alcohol use, then tobacco smoking, consumption of N-nitroso containing foods. The adenocarcinoma, the risk factors are Barrett esophagus, gastroesophageal reflux disease, obesity, and tobacco use. Then the Uworld point is histologically, squamous cell carcinoma demonstrates flattened polyhedral or ovoid epithelial cells with eosinophilic cytoplasm, keratin nests or pulse, and intercellular bridging. The large hyperchromatic cells with bizarre nuclei and atypical mitosis are commonly observed. Location of lymph node spread depends on the level of esophagus that is involved. For the upper one-third, it goes to the cervical lymph nodes. For the middle one-third, mediastinal or tracheobronchial lymph nodes are affected, and for the lower one-third, the celiac and gastric nodes are affected. Then stomach. You remember you should remember the layers of the stomach. Firstly, it is the same pattern is repeated throughout the GAT. So the mucosa, then comes muscularis mucosa, then submucosa, muscularis propria and serosa. If the ulcer is affecting the if the defect is including the mucosa only, like it is affecting the mucosa and muscularis mucosa, so it is called as erosion, right? And the granulation tissue is formed. If it invades the submucosa, then it is called as an ulcer. So talking about gastritis, firstly we'll talk about, as the name indicates, it is the inflammation of the stomach. Acute gastritis, erosion can be caused by NSAIDs, burns, and brain injury. Why NSAIDs? Because the NSAIDs are responsible for decreasing the prostaglandin E2, which decreases the gastric mucosal protection. So the burns, like the curling ulcer, they happen when there is hypovolemia because of burns, and in burns, since the person is not having the skin, so that excessive dehydration occurs, and that will lead to hypovolemia, and that will ultimately lead to mucosal ischemia. The brain injury or the Cushing ulcer, in that there is increased vagal stimulation. Vagal stimulation leads to increased acetylcholine and increased acid production in the stomach, and that causes excessive ulcer formation. So in the NSAIDs, the problem is decreased protective mechanism. The in brain injury or even in the burns, the problem is decreased protective mechanism because the blood flow to the stomach is also protective against ulcers. In dehydration or hypovolemia, the blood is not flowing to that area. In brain injury, the problem is that there is too much acid secretion, and that results in gastritis. Especially common among alcoholics and patients taking daily NSAIDs. For example, patients with rheumatoid arthritis burned by curling iron. So that is, but curling ulcers are seen in burns, and always cushion the brain. So Cushing ulcer in the brain. Stress-related mucosal disease. In shock, trauma, or burns, hypovolemia and hypotension occurs that lead to local ischemia that decreases the mucosal protection, and ultimately erosion and ulcer formation will be there. In intracranial disease, there is vagal stimulation that increases the H-positive secretion, and ultimately erosion and ulcer formation will take place. The Uworld point is about acute erosive gastritis, limited to the mucosal layer. In gastric ulcer, it penetrates through the mucosal layer and extends to the submucosa. Histology of the stomach is surface. On surface, we have mucous glands, upper glandular layer. Parietal cells lead in upper glandular layer, so there are parietal cells which secrete HCl and intrinsic factor secretion. The deep glandular layer produces the chief cell, and pepsinogen secretion will happen from there. The chronic gastritis, mucosal inflammation often leading to atrophy, that is hypochlorhydria and hypergastrinemia, and intestinal metaplasia, increased risk of gastric cancer. H. pylori, most common, and increased risk of peptic ulcer disease and mild lymphoma. It affects the antrum first and spread to the body of the stomach. The autoimmune gastritis, autoantibodies to the parietal cell and intrinsic factors are formed that increase the risk of pernicious anemia and affects the body fundus of the stomach. Then the Uworld point is mechanism. H. pylori induced duodenal ulcer. H. pylori in the antrum leads to the destruction of somatostatin secreting cells in the antrum that increases the gastrin and increases HCl and duodenal cells formed. The important point is that in the H. pylori mediated gastritis, and we are talking about chronic gastritis now. So in H. pylori mediated gastritis, that there is destruction of the somatostatin producing delta cells, right? And that causes an increase in the gastrin production. HCl secretion is increased, and there will be duodenal ulcer. But H. pylori associated, the reverse is true for autoimmune one, because in autoimmune we are destroying the parietal cells, so there will be achlorhydria. The HCl production will be decreased in autoimmune gastritis. So yes, yes. So, but H. pylori associated gastric ulceration result mainly from the destruction of local mucosal cells and local inflammatory response against the bacteria. The NBME point is when you find a duodenal ulcer in the pulp, find the H. pylori in the antrum. The Uworld point, long-standing vague epigastric pain not related to food, and endoscopy shows erythema of the antral mucosa with inflammatory cell infiltrates. The diagnosis is type B chronic gastritis, H. pylori in the gastric antrum. Chronic non-atrophic gastritis caused by the H. pylori, it affects the antrum, and there is a risk of duodenal ulcer. Chronic atrophic gastritis. In chronic non-atrophic gastritis, the non-atrophic one is caused by H. pylori, and chronic atrophic gastritis caused by both H. pylori and autoimmune. It affects the body and fundus, and there is a risk of gastric adenocarcinoma with that. So this is H. pylori. H. pylori decreases the somatostatin that increases the gastrin, that will lead to increased stimulation of the parietal cells to produce increased amount of acid, and this acid when spills into the duodenum can cause duodenal ulcer, because stomach has some protective mechanism because of the secretion of mucosa and stuff like that, but duodenum has decreased defense mechanism, and because of increased spillage of HCl into the duodenum, there is increased chance of duodenal ulcer formation. Then meneterius disease. Meneterius disease is basically increased convulsions in the stomach. So there are mucosal folds become hypertrophic, and you can think of it as when you do the CT scan, you look a brain-like structure within the abdomen, that is stomach. So hyperplasia of the gastric mucosa lead to hypertrophied rugae, look like brain gyri, causes excess mucus production with resultant protein loss and parietal cell atrophy with acid production. It is precancerous and presents with epigastric pain, anorexia, weight loss, vomiting, edema due to the protein loss. So it is causing protein losing enteropathy as well. Hypertrophic stomach jugi are seen in Zollinger-Ellison syndrome because of hypertrophy of the parietal cells, and Meneterius disease because atrophy of the parietal cells. Another Uworld point is transforming growth factor beta alpha. Transforming growth factor alpha. It is a potent stimulator for the epithelial growth and is secreted by carcinomas, macrophages, and epithelial cells. Meneterial disease is associated with overproduction of transforming growth factor alpha, resulting in the mucosal cell hyperplasia and gastric fold enlargement. However, the condition causes hypoplasia of the parietal and chief cells, resulting in the glandular atrophy with reduced gastric acid secretion. Now let's come to gastric cancer. Most commonly gastric adenocarcinoma. The most common type of cancer of the stomach are adenocarcinomas, then lymphomas, GI stromal tumors, carcinoid. These are the carcinoids are rare, but other tumors are these ones. Early aggressive local spread with node liver metastasis often presents late with weight loss, abdominal pain, early satiety, and in some cases acanthosis nigricans or lesser Tourette sign. It is associated with blood group type A. For some reason, the people who have type A blood group are more prone to develop gastric adenocarcinoma. It is of two types, intestinal and diffuse type. So, intestinal adenocarcinoma, it is associated with H. pylori, dietary nitrosamines like smoked food, tobacco smoking, achloridria, chronic gastritis. Commonly on the lesser curvature, looks like ulcer with raised margin. So, whenever you find an ulcer in the stomach, always do the biopsy because it can be carcinoma. In diffuse stomach cancer, it is not associated with H. pylori, signet ring cells, mucin-filled cells with peripheral nuclei. Stomach was grossly thickened and leathery, that is linitis plastica. In diffuse type, on endoscopy, on gastroesophageal duodenoscopy, you don't find anything because the ulcer is not there. The cancer is within the parenchyma or within the wall of the stomach that is causing the thickening. So there is a chance of missing that, but on clinical suspicion, you have to biopsy the stomach, and if you find signet ring cells, that is the hallmark for diffuse esophageal carcinoma, and the stomach becomes thickened like linitis plastica. That is called as linitis plastica. Varicose node. Varicose node is the involvement of left supraclavicular node by the metastasis from the stomach. The Krukenberg tumor, bilateral metastasis to the ovaries, leads to abundant mucin secretion, signet ring cells. Sister Mary Joseph nodule, subcutaneous periumbilical metastasis. Okay, then signet ring carcinoma consists of cells that do not form glands. Cells often contain abundant mucin droplet that push the nucleus to one side and lead to the characteristic appearance of a signet ring, as you can see in this picture. Intestinal type adenocarcinoma closely resemble the colon cancer, showing well-formed glands that consist of columnar or cuboidal cells. So these are two different types. In intestinal types, we find goblet cells. In well-formed glands, as we find in the with columnar cuboidal cells, as we find in the intestines. And for the signet ring cells, we will find a characteristic signet ring, as you can see in this picture. The Uworld point is diffuse involvement of signet ring carcinoma is due to the loss of E-cadherin. Now, in every part of the body, the E-cadherins are the proteins that anchor two cells together in a tissue, and they also, because of this contact between the two cells, there is contact inhibition of mitosis. But if the E-cadherins are lost, every cell is free to divide, and when the cells are dividing freely, so that is going to increase the chance of malignancy. So prognostic factors in the gastric adenocarcinoma is number one, depth of invasion through the gastric wall and lymph node involvement. Peptic ulcer disease, PUD, the gastric ulcers and the duodenal ulcers. For the gastric ulcers, the pain can be greater with the meals, and that will cause weight loss. H. pylori infection is found in 70% of the cases. Mechanism is decreased mucosal protection against the gastric acids. Other causes include NSAIDs. There is an increased risk of carcinoma formation, and other associated points are biopsy margins to rule out the malignancy. In the duodenal ulcers, the pain decreases with meals, and that will result in weight gain. H. pylori infection is found in 90% of the cases. Mechanism is decreased mucosal protection and increased gastric acid secretion. Other causes include Zollinger-Ellison syndrome. The risk of carcinoma is generally it is benign condition, because there you must think of a rule that, not a rule but basically a phenomena, that the malignancies of intestines of the small intestine is very rare, right? So since duodenum is a part of small intestine, so the malignancy of this area is also a rare thing. Others are hypertrophy of the Brunner gland that can be seen on biopsy. The human point is abdominal pain with GERD or peptic ulcer with diarrhea. It is Zollinger-Ellison syndrome. Then stress ulcer, multiple small circular, mainly in the stomach due to impaired oxygenation. Curling ulcer is seen in the proximal duodenum. The Cushing ulcer in any site, esophagus or stomach or duodenum, due to increased intracranial pressure and increased vagus stimulation that will lead to increased HCl production. Next viewable point is most common site of duodenal ulcer is the duodenal pulp, first part of the duodenum. H. pylori induced duodenal ulcer. Site of organism is pre-pyloric area of the gastric antrum where there are few acid secretory parietal cells. As a result, biopsy of the pre-pyloric area would have the greatest yield of the organisms. Colonization of the gastric antrum by the H. pylori is associated with the increased gastric acid secretion, and the duodenal bulb is the area most exposed to the increased acid in the to this increase in the acid production. These organisms are susceptible to gastric acidity but are protected by the mucus layer and endogenous urease production. Urease converts urea to ammonia, alkalinizing the surrounding pH, which allows the bacteria to survive but also injures the gastric epithelial cells. The damage, so basically the ulcer formation um, in the cases of H. pylori infection is also because of urease. Damage to the gastric mucosa is compounded by the localized inflammation due to the immunologic response against the H. pylori. H. pylori associated enteral gastritis is usually seen as an early manifestation of H. pylori infection. Chronic enteral inflammation leads to a decrease in number of somatostatin producing cells that are delta cells. Somatostatin is a hormone that inhibits the gastrin release. In the absence, high gastrin levels act both directly via the cholecystokinin B receptors and indirectly via histamine released by enterochromaffin-like cells to increase the hydrogen ion secretion by the parietal cells. This results in gastric fluid with very low pH that is not adequately neutralized by the duodenal bicarbonate production, leading to the duodenal ulceration and duodenal gastric metaplasia. So again, this type we have seen this diagram. This is H. pylori causing the decrease in somatostatin, which will increase the gastrin production. That will increase the parietal cells to secrete an increased amount of H positive and HCl that will cause the duodenal ulcer formation. H. pylori associated gastric ulceration. So that was H. pylori associated duodenal ulceration, I guess. Now how the gastric ulceration forms. In the stomach, it results mainly from the destruction of local mucosal layer and the local inflammatory response against the bacteria. Acid secretion is most often low to normal in the patient with the gastric ulcers. So the people who have gastric ulcer, the acid secretion is low to normal. Initially, because of somatostatin inhibition, the gastrin production increases and acid production also increases. But since it is atrophic and it is destroying the mucosa of the stomach, so in the long run, the acid production is decreased. However, normal level of gastric acidity are sufficient to cause gastric ulceration when the mucosal layer is degraded. Decreased number of somatostatin producing cells do not contribute significantly to the formation of gastric ulcers. Then another Uworld point is rapid urease test for the detection of H. pylori infection. Urease converts the urea to carbon dioxide and ammonia, causing the pH increase and resultant color change of the phenol red pH indicator. An alkaline color persisting more than 5 minutes is considered a positive test for H. pylori. Although the pink color typically develops within 30 minutes when H. pylori is present, the sample should be observed for 24 hours before being considered negative. Then what are the complications of ulcers? Hemorrhage, obstruction and perforation. Hemorrhage, the gastric duodenal ulcer, posterior more than anterior. So for the duodenum, like suppose this is the duodenum and previously we had stomach and esophagus. So on the posterior wall of the duodenum, we have the gastroduodenal artery. If the ulcer perforates here, it can cause bleeding from the gastroduodenal artery. Most common complication, ruptured gastric ulcer on the lesser curvature of the stomach that will lead to bleeding from the left gastric artery, and ulcer on the posterior wall of the duodenum leads to bleeding from the gastroduodenal artery. Obstruction, pyloric channel and duodenal. So that ulcer can cause pyloric obstruction as well as the duodenal obstruction, perforation, duodenal anterior. So perforation mostly happen on the anterior aspect of the duodenum than the posterior, but if it happens on the posterior, it can cause hemorrhage. May see free air on the diaphragm, under the diaphragm, as you can see in this picture. So here you can find free air in the under the diaphragm on both sides with referred pain to the shoulder via irritation of the phrenic nerve. The Uworld point has distal duodenal ulcer with upper normal limit gastrin, which rises in response to IV secretin, that is Zollinger-Ellison syndrome. Ulcer beyond the duodenal bulb with Zollinger-Ellison syndrome. Normally secretin decreases the gastrin. This test is used to distinguish the atrophic gastritis, that is decreased gastrin, and Zollinger-Ellison syndrome, that is increased gastrin. Then malabsorption syndrome. The Uworld point is causes of malabsorption, pancreatic exocrine insufficiency. Chronic pancreatitis and cystic fibrosis belongs to this group of disorders. Diminished production of the digestive pancreatic enzymes leads to impaired hydrolysis of nutrients in the small intestine. Intestinal mucosal defects examples include celiac disease, tropical sprue, Whipple disease, Crohn's disease, and many others. The structural defect or injury to the intestinal epithelial cells hampers the nutrient transport from the intestinal lumen and or from the intestinal cells to the peripheral organs. Bacterial proliferation. This occurs in small bowel with surgically created blind loops, small bowel diverticulosis, and diabetic neuropathy. The bacteria compete for nutrients, causing the relative nutrient deficiency. The clinical picture is diarrhea, steatorrhea, weight loss, weakness in vitamin and mineral deficiencies in the malabsorption syndromes. So the Uworld point is vitamin E deficiency primarily serves to protect the fatty acids from oxidation. Vitamin E deficiency predisposes cell membrane to oxidative injury. The cells that are most susceptible include neurons with long axons due to the large membrane surface area and erythrocytes due to high oxygen exposure, that is acanthocytes. So in vitamin E deficiency, the acanthocytes will be formed. The most common clinical manifestation of vitamin E deficiency are neuromuscular disease like skeletal myopathy, spinocerebellar ataxia, and polyneuropathy, and hemolytic anemia. Involvement of dorsal column in the spinal cord is associated with a loss of proprioception and vibratory sense. Spinocerebellar tract involvement causes ataxia. Peripheral nerve dysfunction results in hyporeflexia. Now here you can see vitamin A deficiency causes insufficient. The causes of vitamin A deficiency are insufficient dietary intake, pancreatic insufficiency, that is chronic pancreatitis or cystic fibrosis, cholestatic liver disease, biliary obstruction, intestinal malabsorption, that is inflammatory bowel disease, and bariatric surgery. The clinical features include night blindness, severe eye dryness and corneal ulceration, keratinization of skin, growth retardation, and immune impairment. The nutrient deficiencies associated with malabsorption are as follows. For iron, folate, and vitamin B12 deficiencies, they all can lead to anemia, and they can happen in the malabsorption syndromes. The protein malabsorption lead to muscle wasting and edema. Vitamin K malabsorption will lead to petechiae and easy bruising. For calcium and vitamin D, bone pain, muscle weakness, and tetany will occur. With vitamin A deficiency or malabsorption, hyperkeratosis and night blindness can ensue. So the diagnosis is screen for fecal fat by the Sudan stain. The Uworld point is first step of diagnosis of malabsorption is Sudan 3 stool stain and confirmed by fat in the stool more than 7 grams per day. The celiac disease, gluten sensitive enteropathy, and celiac sprue. It is the definition of celiac disease. It is gluten sensitive enteropathy, and it is also called as celiac sprue. The symptom of celiac disease are gastrointestinal symptoms include abdominal pain, nausea or vomiting, diarrhea, and rarely constipation as well, flatulence and bloating. The extra-intestinal manifestations include short stature and weight loss, iron deficiency anemia, and dermatitis herpetiformis. The diagnosis is increased tissue transglutaminase IgA antibodies, anti-endometrial antibodies, duodenal biopsies showing increased intraepithelial lymphocytes and flattened villi. Autoimmune mediated intolerance of gliadin, gluten protein found in the wheat, hypersensitivity to gluten will lead to malabsorption and steatorrhea. Associated with HLA-DQ2 and HLA-DQ8 and Northern European descent, dermatitis herpetiformis will lead to decreased bone density. The findings include IgA anti-tissue transglutaminase, anti-endometrial and anti-deamidated gliadin peptide antibodies, villus atrophy, as you can see in the picture A, so these will be present, and intraepithelial lymphocytosis. Okay, moderately increased risk of malignancy like T-cell lymphoma. Decreased mucosal absorption primarily affects the distal duodenum and or proximal jejunum. The D-xylose test typically absorbed in the proximal small intestine. Blood and urine level decrease with the mucosa defects or bacterial overgrowth. Normal in the pancreatic insufficiency. The treatment is gluten-free diet. Got it. So there will be villus atrophy, cleft hyperplasia, and Brunner gland found only in the duodenum will be found in the celiac disease. Okay, so Brunner glands, like this is the biopsy of the duodenum. And here you can see that we can find intraepithelial macrophages and lymphocytes, not macrophages, lymphocytes. Okay. Then another Uworld point is IgA anti-tissue transglutaminase and IgA endometrial antibodies are very sensitive and specific for the diagnosis of celiac disease. Small intestinal biopsy is confirmatory. Then Uworld point about dermatitis herpetiformis is group of small vesicles on the extensor surfaces and they are extremely pruritic. Immunofluorescence reveals IgA at the dermal papillae. Then comes the lactose intolerance. It is because of lactase deficiency. It can be acquired or congenital. Normal appearing villi except when secondary to injury at the tips of villi, like by the viral enteritis. Osmotic diarrhea with decreased stool pH. Colonic bacteria ferment the lactose. The Uworld point is that a confirmatory test of lactose intolerance is decreased stool pH less than 6, High amount of undigested lactose in the blood attracts excess water in the volume, leading to osmotic diarrhea. In addition, bacterial fermentation of the lactose produces short-chain fatty acids that are acetate, butyrate, and propionate, which lowers the stool pH less than 6 and hydrogen gas, which causes flatulence. Lactose hydrogen breath test. It is positive for the lactose malabsorption if post lactose breath hydrogen varies from more than 20 parts per million, so ppm, compared with the baseline. Pancreatic insufficiency. It is due to the pancreatitis, cystic fibrosis, and obstructing cancer. It causes malabsorption of fat and fat soluble vitamins A, D, E, and K, as well as vitamin B12, decreases duodenal pH, bicarbonate, and fecal elastase. Uworld point about recurrent pulmonary infection and malabsorption is a Caucasian child with suggestive of cystic fibrosis. So, in Uworld, they give you questions like that. Then we have cystic fibrosis, the pathophysiology. The cystic fibrosis transmembrane conductor regulator CFTR is non-functional. This membrane protein is normally responsible for transporting the chloride ions across the mucosal epithelial cells. When the CFTR gene is mutated, transport of chloride and water from the cell is suppressed, leading to secretion of viscous mucus. There is stasis and accumulation of these viscous secretions in the tissue. The most pronounced changes in cystic fibrosis are seen in respiratory tract and pancreas. The male reproductive system, liver, and salivary glands may also be involved. Characteristic findings in the lungs. Since the mucus is thickened, so there is increased viscosity of the bronchial secretions, leading to impaired mucociliary clearance of the bacteria. Repeated pulmonary infections lead particularly with the Pseudomonas aeruginosa are characteristics, and mucus plugging of bronchi causes dilation and bronchiectasis. The pancreas. Viscous pancreatic secretions are not transported to the intestinal lumen and instead accumulate in the pancreatic ducts. The pancreatic insufficiency causes the symptoms of malabsorption like steatorrhea and poor weight gain. The pancreatic secretion form mucus plugs that with time totally obstruct the ductal lumen, the ductal lumina, leading to fibrosis of pancreatic tissue. The intestine. Decreased secretion of the water by the intestinal epithelium may cause intestinal obstruction as well. So the neonates with cystic fibrosis may develop meconium ileus because the meconium will be so thickened that it will plug the ileum. So the ileum will, the peristalsis will be lost and there will be intestinal obstruction causing meconium ileus. The reproductive system, there will be male infertility due to associated bilateral absence of vas deferens. The diagnosis: elevated sweat chloride levels, nasal potential difference measurement, and genetic testing for CFTR mutations. Then talking about tropical sprue, similar findings as celiac sprue affects the small bowel but responds to the antibiotics. Cause is unknown but seen in residents or recent visitors to the tropics. Decreased mucosal absorption affecting the duodenum and jejunum but can involve ileum with time. Tropical sprue, it is associated with the megaloblastic anemia due to folate deficiency and later vitamin B12 deficiency. Whipple disease, infection with Trophyriema whippleyi, intracellular gram positive, PAS positive forming macrophages in the intestinal lamina propria B and mesenteric nodes. Cardiac symptoms, arthralgia, and neurologic symptoms are common. Diarrhea, steatorrhea occur late in the disease course, most common in the older men. Foamy whipped cream in a can. Glycoprotein in Trophyriema whippleyi, positive PAS and diastase resistant. PAS stains glycoproteins, not neural lipids. Neutral lipids. So the neutral lipids can be identified with a multitude of stains, including the Nile red or Sudan black, with the latter becoming useful for the frozen sections. Another Uworld point after pancreatectomy, which is normal, intestinal D-xylose absorption. The D-xylose, like glucose and lactose, is a monosaccharide that can be absorbed without action of pancreatic enzymes. The D-xylose test used to test the brush border absorptive function independent of the pancreatic function. So if there is malabsorption and we give D-xylose, if the D-xylose absorption is okay, so it means that malabsorption is because of some other cause, the intestinal epithelium is fine. But if even the D-xylose is not absorbed, so then we find that the problem is with the intestinal mucosa. Okay, because it is not absorbed, because it is absorbed without the action of pancreatic enzymes. Then the Uworld point is tried with malabsorption with foamy epithelial cells at the tip of the villi. It is A beta lipoproteinemia that causes accumulation of lipids in the absorptive cells in the intestinal epithelium. The enterocytes contain clear or foamy cytoplasm, which is more prominent at the tips of villi. It is caused by impaired formation of apolipoprotein B containing lipoproteins. The ApoB100 is found in the VLDL and ApoB48 is present at the chylomicrons. It is an important MCQ. that ApoB100 is found in the VLDL and for B48 is found in the chylomicrons. During the synthesis of ApoB containing lipoproteins, the microsomal triglyceride transfer protein MTP function as a chaperone protein necessary for proper folding of the ApoB and also participates in the transfer of lipid to the newly formed chylomicrons and the VLDL particles. A beta lipoproteinemia is most commonly caused by an autosomal recessive loss of function mutation in the MTP gene. The clinical picture is that it manifests during the first year of life with symptoms of malabsorption. The lab studies will show very low plasma triglyceride and cholesterol level and chylomicrons. The VLDLs and ApoB are entirely absent from the blood. Then educational objective is that A beta lipoproteinemia is an inherited inability to synthesize the apolipoprotein B, an important component of the chylomicrons and very low density lipoproteins. Lipid absorbed by the small intestine cannot be transported into the blood and accumulate in the intestinal epithelium, resulting in the enterocytes with a clear or foamy cytoplasm. Inflammatory bowel diseases. So these are very, very important. So you must remember both of them, like Crohn's disease and ulcerative colitis. So there are some similarities and some differences. So we'll talk about them one by one. So firstly, let's talk about Crohn's disease. So location, any portion of JLT starting from the mouth to the anus, usually the terminal ileum and colon. Skip lesions and the rectum will be spared. The gross morphology, there will be transmural inflammation that will cause the formation of fistula. Cobblestone mucosa, creeping fat, bowel wall thickening, string sign on the barium swallow on X-ray, and linear ulcers and fissure will be present. The microscopic morphology will show non-caseating granulomas. They are hallmark of Crohn's disease. Like they may not be present in every clinical situation, but if they're giving you a question of Crohn's disease and they tell you granuloma, it's definitely Crohn's disease. And lymphoid aggregates in TH and lymphoid aggregate in this one is TH1 mediated immune response. The complications are similar in both these diseases: malabsorption, malnutrition, colorectal cancer, increase with pancreatitis. So these complications are associated with both type of IBD, either Crohn's disease and ulcerative colitis. Then the complications that are specific to Crohn's disease are fistulas like enterovesical fistula, which can cause recurrent UTI and hematuria, phlegm or abscess, stricture causing the obstruction, and perianal disease. The intestinal manifestations, diarrhea that may or may not be bloody. Extraintestinal manifestations are common to both of them. They can cause rash, that is pyoderma gangrenosum and erythema nodosum. Eye inflammation, that is episcleritis and uveitis. Oral ulcerations, aphthous stomatitis, arthritis, that is peripheral spondylitis. These things can be present. Then extraintestinal manifestations specific to Crohn's are kidney stones, usually the calcium oxalate gallstones, because terminal ileum is involved. May be positive for anti-Saccharomyces cerevisiae antibodies. The treatment is corticosteroids, azathioprine, antibiotics like ciprofloxacin, and metronidazole and infliximab and adalimumab. For Crohn, think of a fat granny and an old crone skipping down the cobblestone road away from. Okay, if you can remember this, good. Otherwise, remember the stuff that we just discussed. Ulcerative colitis. Location is colitis, colon inflammation, continuous colonic lesion, always with a rectal involvement. So rectum will always be involved in ulcerative colitis. The gross morphology is mucosal and submucosal inflammation only. Fiber mucosa with superficial and or deep ulceration. So this is normal and this is the one with ulcerative colitis. With disease, loss of hosta led by appearance on imaging will be present. The microscopic morphology will show crypt, abscess, and ulcers. Bleeding, no granuloma will be present, and this disease is Th2 mediated. You must remember that Crohn's disease is Th1 mediated, while ulcerative colitis is Th2 mediated. Okay. Then complications: malabsorption, malnutrition, colorectal cancer, increased risk with pancreatitis. Then specific complications include fulminant colitis, toxic megacolon, which is life-threatening, and perforation. Intestinal manifestations include bloody diarrhea, which is present with ulcerative colitis. Extraintestinal manifestations include rash, pyoderma gangrenosum, and erythema nodosum. Eye inflammation, episcleritis, and uveitis. Oral ulceration, aphthous stomatitis, and arthritis, peripheral spondylitis. Then specific ones include primary sclerosing cholangitis associated with P and K. Treatment is 5 aminosalicylic acid preparations, for example, mesalamine, 6 mercaptopurine, infliximab, and colectomy, if we are suspecting some dangerous condition like colorectal cancer or toxic megacolon. Ulcerative colitis causes ulcers. So ulcers, large intestine, continuous colorectal carcinoma and cleft abscess, extends proximally, that will cause red diarrhea and sclerosing cholangitis. So the complications of Crohn's disease, the intestinal complications include fistulas, strictures, abscess, perianal disease, and increased risk of adenocarcinoma, which occurs with colitis. In skin, there can be pyoderma gangrenosum, which is more common with ulcerative colitis, and also erythema nodosum. In joints, we can find arthritis and ankylosing spondylitis. In eyes, iritis, uveitis, and episcleritis can occur. For malabsorption, there can be gallstones and oxalate kidney stones. B12 and folate deficiency and anemia can also occur. In the liver, primary sclerosing cholangitis, which is also more common with ulcerative colitis, and increased risk of cholangiocarcinoma. So here they are telling you about the characteristic findings that we see in the Crohn disease. So I guess we'll see this picture in the next session. Until then, Allah Hafiz, fi amanillah, and take care.